Thanks very much for joining us for this meeting today. This is the lower GI endoscopy session, and we're hosting it obviously on behalf of iEcho and indeed the whole project ECHO is part of the platform that we're using. Today's meeting is going to deal with a very topical problem of serrated adenomas, and also one of the very rare syndromes that they are associated with. And we have one of the disciples from Baragwanath, one of Bekesh's disciples, who's, I'm pleased to say, has stepped up to the plate to present this case and to present the sort of messages from it. So Siyanda, thanks very much for bringing this case forward, and we look forward to hearing your messages regarding serrated adenomas and their association with syndromes. Over to you, Siyanda. You can share your screen now.
Thank you, Prof.
You need to go into presentation. That's great. Well done.
Okay. Thank you, Prof. Yeah, this is a case that I'd seen together with Dr. Lala, and he thought that it would be important to present on it to highlight the prevalence of the serrated polyposis syndrome, and also just highlight some of the issues that have to do with serrated sessile lesions. So contrary to what we might be tempted to think, serrated sessile lesions are not adenomas. They present their own challenges, and for one, they're difficult to detect. They're associated with an increased risk of incident metachronous lesions, and they have a high rate of post-colonoscopy colorectal cancer in occurrence. And little is known about SSLs, their genetics, and their behavior when compared to adenomas. So we had a 39-year-old gentleman who had no known comorbidities, was a recreational cannabis user, and his background history was significant for 3 previous scopes, which all had noted polyps. The last endoscopy that he'd had was in 2020, earlier this year, which had reported 4 rectal polyps with an associated sessile polyp at the splenic flexure. The histology had come back on that, showing a hyperplastic rectal polyp. There were 2 large sessile polyps at the hepatic flexure, as well as the transverse, which the endoscopist was a bit reluctant to remove, and he then left them in situ and referred the patient then to Dr. Lala. The family history for this patient was significant in that the maternal aunt also had a history of polyps, as well as his brother, who's a medical professional, also had some polyps removed. He was seen by a geneticist previously and was found not to have any genetic predispositions. So his examination was essentially unremarkable. He had a BMI of 24, and the rest of his systems were normal. Gastroscopy, which was done, was normal as well. And the colonoscopy, which was done that day, found that he had 17 polyps that were found throughout the large bowel, and these were then resected. I've got some images to show from those from some of those polyps. If you look at the top left corner, you may see how difficult it is to spot an SSL. This is a still image, so it's a picture, so it's perhaps easier than when you're doing a colonoscopy and you don't know which area one should focus on. This particular SSL is on the fold. As you can see, it's covered typically by a mucus plug. And it's quite, you can't distinguish the borders of the SSL from the surrounding mucosa. And it looks slightly pale compared to the surrounding mucosa. We then proceeded to inject it. This was with methylene blue. But first, before that, we looked at it under narrowband imaging, just to make sure that there were no features which would concern us for any malignancy. And then Dr. Lala then proceeded to inject methylene blue. And the benefit of methylene blue is you can then appreciate how it clearly demarcates the borders of the SSL. And in that case, it makes your resection a lot easier because you know exactly which areas you need to remove. Okay, this is another example. In the top left, the only clue that you may have to an SSL is that mucus plug. And so as a general rule, if you do see a mucus plug, always be wary to have a second look around to make sure that you're not missing an SSL. This was also subsequently removed. All of these were removed via piecemeal cold snare. And then it was sent off for histology, which came back confirming multiple serrated polyps. And then there was a concern for serrated polyposis syndrome. Thankfully, there was no evidence of dysplasia or malignancy in these lesions. So serrated polyps are described in as elevated lesions with abnormal proliferation. They have dilated and distorted crypts, as well as areas of focal nuclear atypia. On your histology, they tend to have a sawtooth appearance, which is more appreciated on the luminal edge of the crypts. 3 subtypes are described, that being your hyperplastic polyps, your traditional serrated polyp or adenoma, and your sessile serrated lesion. Some people refer to it as sessile serrated polyp or adenoma. And these were initially the hyperplastic polyps were seen in 1929. And it was thought that they were mostly benign, which we know is true for hyperplastic polyps. However, in 1996, Tolakovic and Snova had a case series of 6 patients presenting with large polyps and colorectal cancer. It was at this point that it was recognized that sessile polyps have malignant potential as well. Since then, there's been some development with the move towards more standardized nomenclature for these polyps, as well as the WHO has published various guidelines to try and standardize the diagnosis. And this helps in terms of research if you're looking for a particular cohort of patients that you want to look at, as well as it improves the agreement between pathologists and so leads to a more accurate diagnosis of these lesions. In the general population, at least 40% of adults harbor at least one sessile polyp. Risk factors for sessile polyps include smoking, which increases or has a relative risk of 2, alcohol use, where the relative risk is 1.33, obesity, where the relative risk is 1.4. Other factors that are known to increase your risk of sessile polyps include Caucasian race, female sex, as well as a diet that's high in meat and fat. There are some factors which have been found to be protective as well. Those include NSAID use, a diet that's high in folate, as well as calcium and fiber. As I said previously, the 3 types would include your hyperplastic polyps. These account for the highest number of serrated polyps that you'll see. They account for about 70 to 90% of all serrated polyps. They have a low malignant potential, and endoscopically, they have a pale color with indistinct borders. Most of the time they're found on the left side of the colon, and usually it's unusual that you find them getting above a size of 5 millimeters. The other polyps, the other group is the traditional serrated polyp, which accounts for less than 1% of all the serrated polyps. And these tend to be found in the distal colon. They're reddish and villous in appearance, and they have a malignant potential and should be resected. Then in between, you've got the sessile serrated sessile lesion, which account for 3 to 9% of all serrated polyps. They usually are flat. They have an affinity for the splenic flexure, as well as the right side of the colon, which makes them a challenge to remove. The median age of presentation for patients with serrated sessile lesions is 61. Endoscopically, they appear pale. They have one giveaway, which is that usually they're covered with a mucus cap. And an NBI, one can appreciate then the varicose microvascular vessels and dark spots within the crypts. And they have a malignant potential as well and should be resected. Thankfully, most of these lesions, as I said, are hyperplastic and have little to no malignant potential. But there is before one would, let's say, progress or have a risk of developing malignancy, there are some developments that happen. So one would have changes, including microvesicular hyperplastic polyps, as well as goblet cell hyperplastic polyps. And these changes indicate underlying mutations that are intermediate steps in the process of carcinogenesis. For the traditional serrated adenoma and the SSL, both are known to have malignant potential. However, the dwell time, so that's the time between having these changes or the genetic changes or mutations to development of colorectal cancer, is quite variable. And this probably points to the underlying genetic mechanisms, some of which we don't understand all that clearly just as yet. Some case series have reported dwell times that are less than 1 year. Others report times up to 15 years. In one case series which looked at the development of colorectal cancer in sites of previous polypectomy, the reported mean time to development of colorectal cancer was 7.3 years. These adenomas also have a high risk of synchronous colorectal cancer. So it's important that one tries to go through the entire colonoscopy and looks very carefully for an incident synchronous lesion. If one finds an SSL that's greater than 10 millimeters, and these patients are also at a higher risk of developing metachronous lesions. This just provides an overview of the various pathways leading from, either your normal mucosa to your particular adenoma, as well as the neoplasia. The conventional pathway is that which we are most familiar with, the adenoma carcinoma sequence, where there are APC mutations for these patients. Then in syndromes like your Lynch syndrome, there you've got microsatellite instability that's driving the process. And we know that those lesions are associated with colonic as well as extracolonic neoplasia. Serrated polyps follow different pathways. So two pathways are described, which is the traditional serrated pathway as well as the sessile serrated pathway. This slide just highlights the conventional pathway from adenoma to carcinoma, and you see that you initially have an APC mutation, and then subsequent mutations to the KRAS as well as tumor suppressor genes such as the P53, leading then to carcinoma. For the serrated sessile polyps, as I described, there's the two pathways. The sessile serrated pathway, there you've got a BRAF mutation as the initial lesion or initial event, leading then to the development of an SSL. Once you've got the SSL, you then have abnormal methylation, which then leads to microsatellite instability and the development then of colorectal cancer. With the traditional serrated pathway, you have a KRAS mutation, which leads to the traditional serrated adenoma. And then you have subsequent abnormal methylation, which leads to also microsatellite instabilities and results in neoplasia. So the issue with a lot of the time with serrated polyps is that a lot of these lesions are missed, and because there were different diagnostic criteria by the WHO, a lot of the time patients with serrated polyposis syndrome would go undiagnosed and even unrecognized. The serrated polyposis syndrome is characterized by the presence of numerous colorectal serrated polyps. The prevalence is thought to be 1 per 111 colonoscopies. These patients are diagnosed usually around the 5th decade of life, and the incidence of colorectal cancer in this population is up to 70%. There's no genetic test that can pick up these lesions, so the true genetic etiology for the meantime still remains elusive. I think if one looks at it, this is the most common polyposis syndrome that we see, and it seems to be growing in incidence, and maybe that's just a matter of improved colonoscopy skill, as well as standardization of the diagnostic criteria. There's the latest published diagnostic criteria from the WHO were published in 2019, and there were a revision of previous criteria that were published in 2010. And currently, in order to meet the diagnosis of sessile of SPS, you then need to just qualify for two criteria. So one needs to have more than 5 serrated lesions or polyps proximal to the rectum, and all of them being greater than 5 millimeters in size, with at least 2 being greater or equal to 10 millimeters in size. This was a move away from the previous criteria, which had excluded the sigmoid colon. And this criteria, in the revised criteria in 2019, they recognize that there's also a risk of developing colorectal cancer as a result of these lesions in the sigmoid colon as well. Then the second criteria is greater than 20 serrated lesions of any size distributed throughout the large bowel, with more than 5 of these being proximal to the rectum. And so they've moved away from the previous criteria in 2010, which was any number of serrated polyps proximal to the sigmoid colon in an individual who has a first-degree relative with serrated polyposis syndrome. And that's just because that criteria would include also diminutive polyps, which don't really increase your risk of colorectal cancer. And also it found that it led to then the overdiagnosis of SPS and over-investigation of these patients that were at a lower risk. So if you've got a patient, how would you then investigate them further? So there's some investigations we'll look at, including the fecal immunochemistry testing, imaging in the form of CT enterography or colonography, colonoscopy, and then we'll look at the role of artificial intelligence in detecting these lesions. So according to the US Preventative Task Force, they recommend FIT testing as part of screening for colorectal cancer. In patients with adenomas, the sensitivity of FIT testing in terms of picking up patients with adenomas is 93%, with a specificity of 84 to 89%. In patients with SSLs, this sensitivity is much less. A prospective study which looked at about 6,200 subjects who received both fecal immunochemistry testing as well as colonoscopies. In that population, they detected SSLs in 1.4% of the subjects, so that's 89 participants. And the FITs and the sensitivity of FIT in terms of picking up any abnormalities there was 12 to 27%, depending on the size of the lesion. And this is thought to be because SSLs being closer to being further away from the lumen, and essentially flat lesions are less likely to have spontaneous hemorrhage, and so that's why you wouldn't pick up blood in the stool. CT enterography, the visualization of SSLs even on CT enterography remains a challenge because of the flat nature of these lesions. A randomized controlled trial comparing CT colonography versus colonoscopy for high-risk SSLs. There they had about 3,000 participants, which were randomized either to CT colonography or colonoscopy, and they found that colonoscopy was far superior with a detection rate of 4.3% versus 0.8% from CT colonography. Sigmoidoscopy is also recommended by the US task force, but we know that these lesions tend to be right-sided lesions, and so sigmoidoscopy would be inferior in terms of picking up these lesions. I think the takeaway message from this slide is that until new diagnostic methods are brought into practice, colonoscopy is the best investigation for the detection of sessile serrated lesions. And if a patient perhaps is asking for alternative tests other than colonoscopy, then one ought to present this data, because I think it's the strongest argument that we have in terms of preferring colonoscopy over all the other non-invasive testing. It's been found that even amongst experienced gastroenterologists, the detection of sessile serrated lesions varies greatly, and in this series it was found to be between 0 to 22%, which is quite worrying. So in terms of quality measures that improve the detection of serrated polyps on colonoscopy, the following three were found to help, and that's the use of HD colonoscopy versus standard imaging. Adequate bowel preparation, which was defined there as split bowel preparation, was superior in terms of assisting in detection of these lesions. Withdrawal times, we know withdrawal times of at least 6 minutes were thought to be effective, although I think now moving more towards a withdrawal time of at least 9 minutes. And then a cecal incubation rate, of course, was important as well. It was found that the gastroenterologists that had a higher ADR also had a better sessile polyp detection rate, although this wasn't always in agreement. So this table just shows you the interventions that may improve your sessile lesion detection rate. And so if we look at slow withdrawal time, high definition, and then the use of chromendoscopy and narrowband imaging. Things that have no benefit would include the use of antispasmodics, good versus adequate bowel preparation, and wide angle and enhanced mucosal views, and right colon retroflexion was also, they didn't find a clear benefit for that. Things that need perhaps more data before we can conclude would include things like the endocuff, as well as AI systems like the GI. So serrated polyps are classified according to the WASP classification, and this is because there's been a lag in terms of the recognition of the importance of serrated polyps. There's been a development of systems which didn't actually cater for them, such as the Paris classification. And therefore, if you use systems like the NICE classification or the Paris classification, you may fail in detecting high-risk serrated polyps. And so a different system was then developed, which is the WASP classification, and it differentiates your hyperplastic polyps from your SSLs as well as your adenomas. And it's just basically, you just follow the line. If you find the presence of a colonic polyp, then you look for the following features. You know, it has a brown color, brown vessels, oval tubular or branched surface, a surface pattern. And depending on that, whether yes or no, you then follow, and it leads to then the detection of hyperplastic as well as sessile serrated adenomas or polyps. On this slide, I'd like to then introduce another important metric. We're quite familiar with the ADR, or the adenoma detection rate, but we're not all that familiar with the proximal serrated polyp detection rate. This is not recommended in guidelines yet as a routine, as a measure to be routinely taken, but perhaps in subsequent or in the future, it will be included in guidelines. What has been found is that the proximal serrated polyp detection rate, so the PSPDR, is inversely related to post-colonoscopy colorectal cancer. And with each percentage increase in your PSPDR, there's a resultant 7% reduction in the incidence of post-colonoscopy colorectal cancer. The graphs on the right-hand side basically put this across in pictures, where you see that the higher your proximal serrated polyp detection rate, then that's if you're looking at graph A, then the lower your hazard ratio in terms of post-colonoscopy colorectal cancer. And this was strongest if you even compare the detection of distal polyps versus proximal polyps. You can see that the measure of the hazard ratio was far lower with the detection of proximal polyps versus distal polyps. So we live in an age where there's a lot of AI that's been introduced in medicine as well as all the other spaces. And if we look at AI and how well it performs in terms of detecting serrated polyps, one of the titles from the articles I came across said that flat colorectal sessile serrated polyp, an example of what artificial intelligence does not easily detect. And it's quite accurate. Various papers have looked at different AI programs using different algorithms, and they all seem to fail when it comes to detecting the SSLs. And that's thought to be because these are mainly flat lesions. But probably as algorithms improves or technology improves, AI may be able to detect these lesions a lot more easier. Also, just to remind you, colonoscopy is the most effective visceral cancer prevention tool in clinical medicine, but but its potential is reduced by extreme operator dependence. So we'll look at the treatment of SSLs or serrated lesions, the optimal endoscopic resection strategy and how to go about deciding that, surveillance, as well as screening for these patients. So in endoscopy, all sessile polyps should be removed. There is an argument where some people say, well, you shouldn't remove diminutive polyps. So those that are less than 5 millimeters. But given how difficult it is to detect these lesions, I think it's only prudent that when one encounters them, that they remove them and ensure that they remove them completely. Serrated polyps are also associated with a high rate of incomplete resection when they are compared to adenomas. factors that make these lesions more challenging to remove include the fact that they have indistinct borders. There's mostly right-sided lesions, and then the sessile morphology also makes it difficult to see them from the background. In terms of if you look at the rate of incomplete resection of these lesions, it was 31% versus 7% for adenomas. So by far, the serrated polyps have incomplete resection, and that's why they tend to be overrepresented in causing post-colonoscopy colorectal cancers. Sessile polyp, serrated polyp histology is also an independent risk factor for incomplete resection, as well as a size that's greater than 10 millimeters. And for this reason, the guidelines or the articles were advocating to say that a lesion that's 10 millimeters or greater requires expertise skills in terms of removal. The determinants for optimal resection strategy would then include the size of your polyp, the location, the morphology of the lesion, as well as the skills of the endoscopist. Small lesions may be removed by cold snare, and then they advocate there for a thin snare, this is because the thin snare or the thick snare seems to have a trend towards incomplete removal of these lesions. Additional strategies that one may employ to ensure the adequate removal of the lesion, as well as to ensure that you have good margins, would include injection of the lesions, like in the examples that I showed before, as that helps to clearly demarcate the borders, and it then becomes easier to remove the lesion. Large lesions, those are lesions greater than 10 millimeters, should ideally be removed by EMR. Careful inspection of the lesion to ensure that it doesn't have any features that may suggest malignancy is important prior to removal of the lesion. It's found that in these lesions, the recurrence rate with removal with EMR is 3.6%. An alternative strategy is also cold snare piecemeal EMR, which has been found to have similar recurrence rates. And so what about endoscopic submucosal dissection? This is ideal for lesions that are high risk for submucosal invasion. It is technically difficult and has a high risk of perforation, especially in the right colon. But the benefit is clear for large rectal polyps, where even the risk of perforation is lower. In terms of surveillance, there's various guidelines that have been published. The US advocates for, if you have a patient with an serrated polyp less than 10 millimeters without dysplasia, then they advocate for a follow-up colonoscopy at 5 years. The Europeans say 10 years, and the BSG, doesn't have any guidance for that specific for serrated polyps. And then if the size is greater than 10 millimeters, the US, they say your follow-up colonoscopy should be at 3 years, and the Europeans also agree. For serrated polyposis syndrome, one has to note that the US advocate for a colonoscopy at least 1 yearly. And then the BSG also follow in light with saying 1 to 2 yearly, and advocate for genetic counseling, while the Europeans advocate for 3-year surveillance. So one would see that the US recommendation, all of these recommendations are mainly based on expert opinion, as there's no real prospective data for them. But various cohorts have shown that patients with serrated polyps, if they have a single non-dysplastic sessile polyp, when they return for surveillance, are more likely to be found to have an advanced neoplasia. And so the risk of them, because of the higher risk of them having another lesion, they ought to be followed up. The exact timeline of when to follow up, is unclear, but one shouldn't return them to the population and say, well, you'll repeat your colonoscopy either in 10 years, or if you have another issue that comes up, they should have a timed colonoscopy. Patients with high-grade dysplasia and sessile polyps, those ones ought to be surveilled, because the risk of colorectal cancer increases 3 to 5-fold when you've got presence of high-grade dysplasia. In terms of screening, the risk of colorectal cancer is 3 to 5 times higher than the normal population for first-degree relatives of patients with SPS, or serrated polyposis syndrome. And first-degree relatives of patients with SPFs should have screening colonoscopies, especially after the age of starting at the age of 40, and then have subsequent colonoscopies every 5 years thereafter. To conclude, I hope I've made the case to you that serrated polyps are not just flat adenomas. They have their own risk profiles. We do, however, there is a big gap in terms of our data from our population regarding serrated polyps and interval colorectal cancer, as well as the prevalence and incidence of serrated polyposis syndrome in our population. And like Dr. Lara likes to say, quality endoscopy is key to the adequate treatment of these patients.
Thanks very much, Siyanda. That's a very comprehensive look into the syndrome itself, and I'm very interested to hear if there's any questions posted in the chat. So there's a couple of questions here, but maybe if I can start with one. Can you actually tell me what the difference between a sessile serrated polyp is and a sessile serrated lesion? Are they different, or are they the same? Are they used interchangeably?
So there is a move away from saying sessile serrated polyp more towards sessile serrated lesion. I think it's just so to avoid confusion amongst pathologists when they're making the diagnosis, so that it's easier to pick up that there's a difference, from your adenomas.
And from the chat room, can you shed more light on withdrawal time? You mentioned it, and we know withdrawal time is important for detecting adenomas. You mentioned the figure of 6 minutes, but in these patients who you've identified with the syndrome, how long do you think you should be coming out? Because obviously they're going to have difficult lesions to detect, and they're at risk from having multiple lesions. And again, perhaps you could relate this back to the index patient as to what you're going to do exactly with him in relationship to his surveillance. So the withdrawal time and specifically how you're going to handle the gentleman that you have, the 39-year-old.
Okay, in terms of the withdrawal time, the studies say, the withdrawal time that's longer than 6 minutes led to a higher detection, sessile polyp detection rate. But I think now we're moving away from the figure of 6 because we found that 9 minutes actually results in higher ADR, and by inference probably should also increase your sessile polyp detection rate as well. For this gentleman, because he had multiple piecemeal polyps that were removed, there were other polyps that we couldn't remove in that session, and so his next follow-up colonoscopy is scheduled in 6 months' time. But according to the guidelines, it wouldn't be longer than 1 year.
And another question is, what's the typical clinical presentation of these patients? Are they identified incidentally when they're endoscoped generally, or how are they identified? And do they come, obviously it's a syndromic problem, but do they come with any other syndromic features? Do they have gastric polyps or cancers at other sites?
Yeah, Prof, this is the unfortunate bit for these patients because really you don't get any clues unless there's a family history that's suggestive. There's no typical examination findings in this population. So usually it would be incidental, or if someone has loss of weight with an iron deficiency, anemia, and PR bleeding. But in terms of the early stages, there isn't actually a typical presentation for them, which also makes it quite difficult to know the true incidence in the population of this syndrome.
That's good. And one other here, can you conceptualize this into the African population? Do we have any data on Africans of African descent as to what their frequency is? We generally know that in rural populations, and some of the data that we do have, that the adenoma detection rate is probably of the order of 1/3, unless they're urbanized Africans. So what do we know anything about serrated polyposis rates in not the syndrome, but the actual sporadic?
This is an area where the fellows ought to probably do some more research in, Prof, because we don't know. It's just sitting in the dark there. I work in Bara, so typically I'm seeing it's mainly a township population, but we do see a fair number of polyps. And I don't know if this is because people's lifestyles have now changed in terms of their diets. People are smoking a lot more now than what they were previously. But compared to what I'm told, compared to previous years or previous decades, we're picking up a lot more polyps now in our Black population.
But we've no real data on serrated adenomas.
But no real data on serrated adenomas. I must say, Prof, even prior to doing this presentation, I myself didn't, I think it would be important to actually delineate, whether endoscopically, I think this is a serrated lesion or, an adenoma. So I of information, and I can also try and track back with the lab to see the histology that we've submitted how many of those polyps have actually come back as serrated versus, adenomas.
Yes. In the study that we did, where we actually paired the polyps with the histology, we had only 2 serrated adenomas out of a population of over 1,000. So I'm not sure. And the big problem is that we might be missing them, I think. And the reason we're missing them is all the factors that you've said there that are to do with quality colonoscopy. And much of the state system doesn't really use split prep, as far as I'm aware, or it's difficult to use split prep. And those are the very patients that you will miss lesions in the right colon, which is particularly where you want to not to miss them. And it does seem from that diagram that you showed of the pathways to cancer that it's probably about 10 to 15% of the cancers that are related to these. And I think as our population ages in Africa, we are going to see much more of the right-sided cancers. And some of their etiology is definitely to do with the serrated adenomas. I'm not sure if anybody else has any questions. I think I've hopefully answered some of that. But the other thing is, obviously, the holy grail really is post-colonoscopy interval cancers. Again, that's not the only cause of missing a lesion, is it? And of course, it depends on your interval for colonoscopy. But some of these lesions have an accelerated pathway.
Yeah.
And it may be that they're truly new cancers. Does anybody have any questions from the other questions? I think this is all that I can see. Chris, do you have any comments you'd like to make?
Yeah, just one comment, Sandy. I mean, detecting them, one needs a high index of suspicion. You've got to kind of anticipate what you're going to find. And I think 2 things that have stood out for me in detecting is to decompress the lumen of the colon, because when you inflate the lumen, these lesions tend to flatten out, and you really don't see them. And it's really quite startling when you decompress the colon that they just stand out. And then secondly, for me, that mucus plug. When I'm coming back, particularly in the right colon, if I see a distinct mucus plug, not just generalized effluent with mucus, but a distinct mucus plug, invariably you wash that off, and underlying that will be a lesion. So those are the 2 things I use to try and detect these lesions, which can be very difficult to see.
And in what roughly how many would you see a year in your practice? Would you say, out of your colonoscopy practice in a year, how many would you see with serrated adenomas? Would you say, just to give us a feel for it?
Wow, 5%.
5%, yeah. Yes, I think certainly in the state sector it's a lot lower than that, but it would be an interesting project for one of the youngsters to take up, because I think they're going to come like a tsunami, and particularly as our standard of colonoscopy improves, we're going to see them more and more. But I think it's a very sort of interesting update, and it's a changing field as well. There's lots of people who are showing a great deal of interest both in these syndromes and in the detection of the isolated lesions themselves, particularly when they're sizable. If there's anybody else who wants to put their hand up and open their heart out to us on the echo, please do that. It seems you've covered all the bases, Siyanda, and I think you've done a great job on highlighting the main controversies and exactly what we should be doing about it. Perhaps one last question. Is there any place for surgery in this gentleman of yours? When would you consider taking out his colon?
I think, Prof, you'd consider taking out the colon if you couldn't control the number of if you couldn't control the number of polyps with colonoscopy or removal with colonoscopy. He didn't have a lot of lesions, and we were also not concerned that any of them were high grade for malignancy. And so at the moment, I think he's probably going to just continue with an endoscopy.
Surveillance and removal. Okay. So it remains for me to thank you and to thank iEcho and iEcho India for hosting us. I think it was an informative session today, and I'd like to thank Siyanda again. The sessions are recorded, and you're welcome to go to the Gastro Foundation website and access them if you want to refresh your memory, especially for the trainees. These are valuable bits of information and references for that. And just to remind you that next week, I believe, is IBD, and that will be another good session for you to attend. So I'd like to thank everyone, all the participants, and enjoy the rest of your day. Thanks very much.
Thank you.